Greetings. I will now be going over Roman numerals 10 and 11 on your checkoff sheet, which is the lungs and the thorax worth 10 points and the breast and axilla worth 5 points. So if you'll get your sheet out, I'll go along and tell you what to expect or what I'm going to expect for the checkoff. All right. I hope these are helpful. So if you'll go to your sheet, you'll see here again, I just did, I got up to Roman numeral 10, the lungs and the thorax. Again, this is worth 10 points, and this starts on page 422 in your book. First thing it says, you're going to inspect the skin. So you always look at the skin. You're looking to see if there's any moles, if there's any abnormalities, if there's any tattoos, anything. So the color should be consistent. There shouldn't be any pallor or cyanosis or lesions noted. So you just do a good inventory of the skin. Then you look at the AP diameter, which is the transverse versus the anterior and posterior versus the transverse. And if you look, the anterior-posterior diameter should be less than the transverse diameter. The ratio of the anterior or the AP to the transverse is about 1 to 2. If it's more equal, then usually they have what we call barrel chest, and you will see that in people with chronic emphysema. So you're looking to make sure that the AP it's not, the ratio of the AP to the transverse is about 1 to 2. Then you're going to assess respiration, the rate and quality and rhythm of the respirations. So you're going to make sure again that the chest is symmetrical, that the respirations are equal and unlabored. Then you're going to see if they're using any accessory muscles to breathe. And you would just state whether they were or were not. To palpate, you're going to be palpating the back for any tenderness. You're going to be checking for what we call respiratory vocal resonance. As you get ready to have the patient say things like 99, you will actually listen as they're saying 99, and then you will put your hands up there as they are saying 99. So you'll listen as they say 99, and then you'll actually put your hands up there as on page 423 as you're checking for tactile pharyngitis. It says pharyngitis is a palpable vibration, and sounds are generated from the larynx and transmitted through the bronchi. And you will feel vibrations as your hand goes down. And what you're doing, it tells you how to do it. 1, 1, 2, 2, 3, 3, 4, 4, 5, 5. You can do it that way, or you can put both hands on both sides and go 1, 2, 3, 4, and 5. I like doing it that way better, both hands, so I can feel if I feel any difference in either side as I'm going down. So you can do that one-handed, or you can do both hands at the same time. Then you're going to check for chest expansion on page 422. It should be symmetrical. You do this by placing your warm hands with your thumbs at the level of about T9 to T10. And you pinch up a small fold of skin between your thumbs, as on the picture on 423. And you ask the person to take a deep breath. Your hands serve as a mechanical amplifier, and as the person inhales deeply, your thumbs should move apart symmetrically. You're going to make sure that there's no lag or uneven chest expansion. That could be pneumonia, pleural effusion, fractured ribs, pneumothorax, if it is an uneven chest expansion and your fingers don't go out about the same way. Then you would check for the level of diaphragmatic excursion. Let's see where that's at in your book. That's on page 426. And to determine diaphragmatic excursion, you're going to use your percussion techniques. And you're going to percuss the lower lobe, both in inspiration and expiration. So the first thing you're going to do is ask the person to exhale and hold it. And while you percuss down the scapular line until the sound changes from resonance to dull. Once it changes from resonant, so you're going downward, downward, downward until it changes from resonance to dull, and you'll mark that. Then you'll have the patient take another breath, because that's estimating the level of the diaphragm separating from the lungs. It may be somewhat higher on the right side, and you mark the spot. Then you ask the person to take a deep breath and hold it, and you continue percussing down from your first mark and mark the level where the sound changes from dull, and measure on this where the sound changes to dull again, and measure that on deep inspiration. And then you measure the difference there. The diaphragmic excursion should be equal bilaterally and should measure about 3 to 5 centimeters in adults. Now, people who are well conditioned, it tells you it can even be up to 7 to 8, but most are about 3 to 5. Okay, about 3 to 5. If it's larger than that, they may have fluid in this space. They may have atelectasis in their lower lungs. So that's how you do diaphragmic excursion. Then you're going to percuss. You're going to percuss your lung sounds in all fields. Again, you can use your finger as we were taught earlier, or you can use a reflex hammer, which is what I prefer to do because you can hear it better. So you will percuss, and it tells you on, let's see where percussion's at. Percussion's on page 432. Tells you how to do percussion, and you will be doing this anteriorly and posteriorly with both lungs when you get ready to actually do this. So you have to do the complete, all this in the front and all this in the back. So to percuss the anterior chest, it shows you what areas to percuss. So you start up there at the clavicle, and then you move down to where it says 2, 3s, 4s at the nipple line, and 5 right below. So you're going to percuss in 5 different spots. Okay, and you should hear resonance when you're percussing. That's what's normal over the lung sounds. If someone has COPD or hyperinflated lungs, then you'll hear hyperresonance. It may be dull. If someone has like large breasts, there may be some dullness there. That's why I prefer to use the reflex hammer instead of just my finger, because you can hear better. You're going to also auscultate all the lungs with inspiration and expiration. Auscultation of the breast sounds is on page 427. If you're looking at the back, you're going to auscultate in 9 areas by having them take full deep breaths, and you will need to do those full 9 areas on the posterior. When you're getting ready to auscultate on the front of the chest, it talks about auscultating the anterior chest on page 433. Okay. You will auscultate the lung fields over the anterior chest from the apices in the supraclavicular area down to the 6th rib on both sides. Okay. Again, it shows you where you'll hear your sounds of resonance, of dullness, and flatness over the bone, as well as tympany over the stomach on page 433. That's where you should hear those sounds. The only way to get good at this is to practice, practice, practice. Who should you practice on? Any willing partner. Also, your normal lung sounds you need to be familiar with on page 428, which are your bronchioles, your bronchial vesicular, and your vesicular. It shows you how to listen to those on the anterior and posterior on page 429. So you will listen for the bronchial vesicular down the middle. You will listen for the vesicular on both sides of that in the back. In the fronts where you hear the bronchial or trachea up in the windpipe, you don't listen to those in the back. Down the sternum, bronchial vesicular, and on each side of your lung fields, vesicular. So you will have to listen for bronchial vesicular, and vesicular, bronchial vesicular, and bronchial. And again, that shows that on page 429. Then you will do your breast exam. You will verbalize this only, and it's worth 5 points. Your breast exam is in another chapter here. Let's see. This one starts on page 392. Inspection of the breast, the skin, and the nipples. Of course, you're going to look at the skin. It should be smooth and even colored. So you're making sure it's smooth and even colored. There shouldn't be any redness, no bulging, no dimpling noted. You're looking at the nipples to make sure they're symmetrical. There shouldn't be any edema. There shouldn't be any discoloration noted. And then once you've inspected real good, then you're going to palpate. And to palpate, you're going to inspect and palpate the axilla as well as the breast. When you're getting ready to inspect, just looking, you want to ask them to push their hands on their hips. So that's one way of slightly lifting their breast so they can look. There shouldn't be any dimpling or anything. You can ask them if they've got large breasts to kind of lean forward a little bit so that you can look at their breast a little bit better. With the inspection, a palpation, you're going to palpate the breast, the nipples, and the axilla. It shows you on page 395 where you're going to palpate the axilla at. How you're going to palpate the breast depends upon which method you want to do. On page 396 goes over the 3 methods. You can do the vertical stripe pattern, as in figure A. You can do the spoke wheel pattern, as in figure B. Or you can do the circular pattern, as in figure C, as long as you inspect the whole breast. And at the end, you pinch the nipple for discharge. You should not feel any there shouldn't be any tenderness, and you should feel no nodes during this time. If you do feel nodes, then we need to have those further assessed. One of the things you want to make sure you remember on page 397, it says normally you may feel a firm transverse ridge of the compressed tissue in the lower quadrants, which is usually right up under the breast, especially in large breast women. That is called the Infra mammillary ridge, and that is not to be confused with abnormal lumps. And if you've got large breasts and you've done under you can feel that intra mammillary ridge really well. And it's even scared me before, thinking that I may have something wrong, but that's just feeling that ridge very, very well. Okay. So again, this part you're going to just verbalize. You won't actually have to do it other than verbalizing, and you can show me on yourself how you would do that. As far as identifying the lymph nodes to assess, you will also need to identify those, and those are on page 385. You will have to know to be able to identify up under the armpit that you are identifying the lateral axillary, the central, or right up under the armpit, the supraclavicular, which is right up behind the posterior, behind the clavicular, the pectoral, which is right in front of the breast area. So you will have to identify the lateral, central, subscapular, and pectoral. Alrighty, that takes care of going over the lungs and the thorax worth 10 points, and the breast and the axilla that you only have to verbalize for 5 points. If you have any questions or concerns about this content, don't hesitate to call me. Thank you very much and have a great day.